I'll be introducing tonight's featured speaker and moderating the question and answer period that will follow the talk. But before I introduce Dr. Graf, I thought I should start with a little brief background on the educational series that we're launching with this program tonight and on the people who made it possible. It's been my honor for the past 5 years to serve as the director of the Russell Engelman Board, which consists of a group of dedicated, hardworking volunteers who have helped to support rheumatology research and education at UCSF. This year, that board, in conjunction with the faculty in the Division of Rheumatology, decided to expand the scope of their work to include free educational programs for people with rheumatologic diseases, for their family and their friends, and for the many people who have supported our programs over the years. Some of the programs that we'll be presenting in this series will focus on specific diseases, such as osteoarthritis, rheumatoid arthritis, juvenile arthritis, to name just a few. And other programs will focus on topics of broader interest to the entire community, such as tonight's program. And of course, tonight we've chosen a topic that's impacted everyone, but that poses special challenges for people with inflammatory and immunologic diseases. Our speaker is Professor Jonathan Graf. Dr. Graf is the co-founder and director of the Rheumatoid Arthritis Clinical Program and Translational Research Program at San Francisco General Hospital. He still manages to do all that, but in the last year, he's also turned his attention to focus on the pandemic, as many other of our faculty members have done. And John and the others have devoted their attention to caring for people with rheumatologic diseases who have encountered COVID-19 and have all become leaders in national and international research to try to understand the particular impact of the pandemic on people with rheumatologic diseases. His talk tonight is entitled "The Virus, the Vaccine, and You, an Update for People with Rheumatologic Diseases." During the presentation, I encourage you all to submit questions via the question and answer function on the screen. I'll be trying to keep track of them, and we'll get to as many as we can during the 20 minutes or so that will follow John's talk. Just remember, don't try to use the chat function, use the question and answer function. The chat function is disabled for this presentation. I should also mention that this program is being recorded and will be available afterwards to you and to anybody you want to inform about it. But keep in mind and be reassured, only the speaker and I will be seen or identified on the recording. And I think that's enough foundation information. Let's turn it over to John Graf now to share his screen and get started. John, why don't you just come on?
Thanks, David. So I'll give a little talk for the first 25 or 30 minutes, I think, and then we're going to engage in a little bit of a question and answer. So everybody feel free to leave any questions that are still in your mind as the talk goes on. And I'll just sort of start by saying that this talk is really aimed, obviously, at a broad audience from the lay public all the way on up to medically savvy people. And it's aimed at a little bit of a high level, but I really am trying to cover things that I think will be of most interest to the general population of all of us, particularly those who have rheumatic diseases. So with that, let me share my screen. There's always a little bit of a pause here. And David, if you could just let me know that you in fact see my screen.
I see your screen.
Great, we're good to go. So, so the talk today is entitled "The Virus, the Vaccine, and You." And I'll start by basically acknowledging what a year it's been. It's been a remarkable year in so many ways, but perhaps the biggest way, at least that I see, is really the amount of discovery that's taken place in just the span of what has now been a little more than a year. Remember, in December, at the very end of 2019, when the WHO was notified that there was a cluster of pneumonia occurring in Wuhan, China. At that time, nobody knew what the cause of the pneumonia actually was. And yet within a couple of weeks thereafter, not only had the cause been identified as a novel coronavirus, but the virus's genome had been published and was available for further study. And about a month later at that point, the virology of the virus had begun to be worked out. And this receptor called the ACE2 receptor, which is the receptor by which the virus engages the host cell and invades it, had actually been discovered. And this was an important discovery that would lead to therapeutics and ultimately to many of the vaccines now that are available to prevent the disease. Barely a month later, when we were developing blood tests to test for antibodies for people who had been exposed to the SARS-CoV-2 virus, we also noticed that the first vaccine, the Moderna NIH vaccine, entered clinical trials. Again, within a couple of months of the discovery of this particular virus. Followed thereon a few months later by remdesivir and other therapeutics. There are now 5 FDA emergency authorized therapeutics to treat COVID-19. And shortly thereafter, a 6th, which is not actually specifically authorized, but perhaps is the most beneficial for treating severe COVID-19, which is the use of the corticosteroid dexamethasone. And of course, to round out the year, in less than 12 months, we actually had an FDA authorized, actually 2 FDA authorized vaccines that appeared to be incredibly efficacious to prevent COVID-19 infection. That's a remarkable timeline of discovery for less than a year. How have we come to have such remarkable progress in our understanding and prevention of this novel pathogen, one that wasn't even known back as late as the end of 2019? Well, this has really come because for a bunch of reasons. There's been incredible collaborations set up all over the world, which include international registries and other modes of data collection. There's been the rapid dissemination of these data as well as clinical experience in treating the disease. And the typical methods of communicating medical progress through stodgy medical journals has sort of been bypassed in the era of the internet, in the era of the ability to publish novel sort of pre-reviewed science through other outlets, and information has been widely disseminated for good and for bad, for that matter, in record time. There's been a remarkable convergence of science that's occurred, particularly in the translational arena of basic virology, immunology, and molecular biology, where experts have come together and collaborated in ways that have brought remarkable discoveries. And again, it seems, it's hard to believe we're really only a year into this. A lot of what I'll talk about today may be old hat to a lot of you out there, but I'll just caution everyone by saying that while we all may think we've sort of been exhausted by the coronavirus in the past year, now really is not the end. And again, paraphrase Winston Churchill, it's not perhaps even the beginning of the end, but it is perhaps the end of the beginning. And that's really where I want to start my talk today. So what have we learned about the clinical course of COVID-19 disease in patients who have rheumatic diseases? Well, again, this is a work in progress, right? We're only a year into this. And so some of these data that I'm going to present today may very well change as we learn more about the nature of COVID-19, particularly as it affects patients with rheumatic diseases. And of course, we're adding to our knowledge every day. And so again, I may, hopefully, if I'm invited back, come talk to you all in the future at some point. I may have completely different data to share. But as of now, we do think that COVID-19 outcomes may be worse in some patients who have rheumatic diseases. We also believe that immunosuppressive medications that our patients take could possibly worsen disease in some, or it even may possibly benefit the clinical course of COVID-19 disease in others, particularly those who have severe disease. It's a paradox that I think warrants a lot of study. We also know that immunosuppression may lengthen the duration of infection and infectivity. And that's something that I think a lot of people may not be aware of if they happen to be immunocompromised and acquire a COVID-19 infection. And then finally, I'm not going to talk about this today because I think that the data are controversial and are still pretty much at the case series level. But there are controversial data, some of which is eye-opening, but I think still controversial, where there has been the report of the onset of clinically apparent autoimmunity and autoimmune diseases that develop in patients who've had COVID-19 infection in the post-illness period as well. And again, I'm not going to talk about that today because I think there's a lot that will come out about that, I think, whether that's true or not in the future. So let's talk a little bit about the registries that I alluded to earlier. Part of the way we've come to understand how this disease behaves in our rheumatic disease patients is through large data sharing. And one of the largest of these is the COVID-19 Global Rheumatology Alliance. This is a remarkable project set up pretty much in the days to week even after the pandemic was declared back now over a year ago. And researchers here at UCSF, which include Janus Yazdani, deserve tremendous credit for reaching out to colleagues, particularly in Europe, to set up this registry. So what is the Global Rheumatology Alliance? It's pretty much a doctor-reported registry. And of course, since it's a doctor-driven registry, it's fraught with potential bias, what we call ascertainment bias, where you would expect that those patients that rheumatologists become aware of are the sickest patients, the one in the hospital, the one with the most severe disease, tend to be reported more to a registry like this than others. That said, there are some very interesting and important data that I think we can glean from registries like this that tell us how COVID-19 behaves in our rheumatic disease patients. So to date, there are over 15,000 patients who have been reported in this registry, relatively equally split, as you can see here with my arrow, between the United States and Europe. The age representation is relatively broad, although as you would expect in our particular population, patients under the age of 30 are somewhat underrepresented compared to the general population. In particular, one population, therefore, that I think is overrepresented are patients over the age of 65. In the general US, and I've put some general statistics here, it's 16%, and in this registry, it's 21%. And as you know, age is one of the major comorbid conditions that's associated with worse COVID-19 outcomes. In terms of other comorbidities represented in the registry, these are comorbidities that we know are associated with severe COVID-19. Some of them are underrepresented in the registry, such as hypertension, for example, or morbid obesity. But others, such as lung diseases, which includes COPD, for example, and interstitial lung diseases, are overrepresented because we know these diseases cohabitate with many of our autoimmune diseases like rheumatoid arthritis. And diabetes is overrepresented as well, probably because we use medicines like steroids that lead to glucose intolerance. And therefore, it's unclear whether or not these comorbid conditions that are overrepresented perhaps tilt the scale towards potentially worse outcomes in our rheumatic disease patients. And again, these numbers on the right here are numbers that I pulled up from various registries of comparing the rheumatology registry to the general US population. Now, a study published by the COVID-19 Rheumatology Alliance just recently looked at deaths in the registry between March and July of 2020 and what tend to be associated with death. And about 10% of the patients in the registry actually had died, which is much higher than what's reported in the general population. And again, I think reflects the fact that there's an increased severity of patients being reported in the registry, not just that there are more deaths in patients who have rheumatic diseases. And in fact, I just checked the current death rate a couple of days ago by logging into the registry, and the death rate had dropped from 10% down to 5%. So meaning that most of the cases that have been added recently are patients who have not died. And that may reflect a more representative population of patients being now included in the registry, or it may very well represent the fact that we've gotten a heck of a lot better at treating COVID-19 over the course of the last year. Nonetheless, if we look at the registry and we look at who are the patients who are dying who have rheumatic diseases, they tend to be the older patients, which is just like in the general population, where older patients over 75 are more than 6 times likely to die. And those who have comorbid conditions like chronic lung disease, for example, or hypertension and cardiovascular disease are also 60 to 80% perhaps more likely to die than patients who do not have those particular comorbid conditions. But I think where the registry really shines, and again, understanding that it's not a perfect study of the epidemiology of COVID-19 and the broader rheumatic disease population, is really what the registry has told us about the characteristics of our patients' particular diseases and their risk of death. So number one, patients whose disease is poorly controlled, no matter what their underlying disease is, if they have lupus, if they have rheumatoid arthritis, if their disease is poorly controlled compared to those whose disease is well controlled or in remission, they have a 1.87 times likely chance of dying, about an 80 to 87% increased chance compared to those whose disease is in low disease activity or remission. That's an important point. Also, regarding medication usage, various medicines are associated with various increased risks of death. But the one that I think jumps out the most in the registry to those of us who sort of looked at it is rituximab, which is a B cell depleting agent, a drug that gets rid of B cells. And it's a drug that's used to treat rheumatoid arthritis as well as ANCA vasculitis. So for those of you who have what's called GPA or Wegener's, for example, may be on this medicine, have a fourfold hazard ratio of dying from COVID-19. Another interesting thing that I think made the list was the use of corticosteroids like prednisone, for example, at higher doses, had an increased risk of death as well. This is interesting because yes, prednisone we know suppresses the immune system and can put patients at risk. But as I alluded to earlier, a corticosteroid called dexamethasone has actually been approved for patients with severe COVID-19 and probably is the most efficacious medicine to date that prevents death in patients with severe COVID-19. So again, it's a paradox that I don't think is very, very well understood, and it may be related to the timing of these medicines. You know, if you get some of these medicines, if you're on them at the time you acquire COVID-19 infection, that's not so good. But once you've got COVID-19, for whatever reason, if inflammation is out of control, then maybe medicines like corticosteroids actually can bring some of that inflammation under control. Now, the COVID-19 Global Rheumatology Alliance data have been backed up by studies of other large data sets. And the only other one I'll mention today is a data set from the VA system here in the United States. These are data published from Ted Michels's group at the University of Nebraska. And Ted's group actually was able to amass a study of over 33,000 patients with rheumatoid arthritis and match them to 33,000 patients without RA. Because this was a VA population, it was older and tended to trend towards men, of course. But in this large population, they uncovered 1,500 diagnoses of COVID-19. And it turned out that the RA patients compared to the non-RA patients were 25% more likely to develop COVID-19, and they were 35% more likely to actually require hospitalization or unfortunately die of the disease. So these data that suggest, and I think back up the point, that patients with rheumatic diseases like rheumatoid arthritis probably are at some increased risk. It's a small increased risk, but it's not a negligible one from having a bad or more severe outcome from COVID-19. Now, I just want to spend a couple of minutes telling some interesting stories as we sort of make our way through 2020. Why do some patients get particularly awful, nasty disease and other ones don't? And it's become pretty clear about the importance of proteins in our bodies called interferons and their relationship to viral infections such as COVID-19. We've known for a long time that interferons in our body are absolutely essential for host defenses against viruses. And this is a study published last year in the Journal of the American Medical Association that looked at two sibling pairs who had particularly severe COVID-19 disease and who were very, very young, less than 35 years old, which is not the typical demographic you would expect to get severe COVID-19. All of these were men, and it turned out that when they sequenced their entire genomes, that these four patients all had mutations in a receptor called toll-like receptor 4. And you don't need to really know what that is, except to know that that receptor is absolutely essential for the host defenses against viruses, particularly viruses that have RNA in them, like the COVID-19 virus, SARS-CoV-2. And in fact, if you have a mutation in this particular receptor, it cripples interferon responses that should be generated against these particular kinds of viruses. There have been subsequent studies that have shown that not only do patients who have genetic predispositions to poor interferon activity get bad COVID-19, but there are also patients who make antibodies to interferons and interferon receptors as well. And it turns out if you look at patients with these antibodies, they overwhelmingly are the ones who get, in many cases with these antibodies, get life-threatening COVID-19. This is a study published in Science now at the end of last year. And it looked at patients with particularly bad life-threatening disease. And those who made interferon antibodies were completely represented in the population of patients who had life-threatening disease. Not everybody with life-threatening disease makes anti-interferon antibodies. But if you look at patients who happen to have the antibodies who get COVID-19, they all get in this particular study, bad COVID-19. And if you look at those patients who had asymptomatic disease, none of them had autoantibodies to COVID-19. So let me just phrase that a little bit differently here. When you look at a population of patients who have life-threatening COVID-19, you can find some that have antibodies to interferons. If you look in patients who have asymptomatic COVID-19, at least in this study, none had antibodies to interferons. Why is this potentially important? Well, we've known for a while that patients who make autoantibodies as part of their disease, like patients with lupus, for example, can make anti-interferon antibodies. Between 27 and 42% of patients with lupus actually can be shown to have anti-interferon antibodies. Now, it's not like there's a rash of severe COVID-19 breaking out in lupus patients. So obviously this isn't the entire answer to the question, but it is very, very provocative, because we use drugs, for example, in treating some of our rheumatic diseases that inhibit interferons. Some of these drugs, called JAK inhibitors, are used to treat rheumatoid arthritis, inflammatory bowel disease, psoriasis, psoriatic arthritis, and such. And so I personally get very, very nervous in patients on JAK inhibitors who come into contact with COVID-19. Now, it's also interesting, just like there's that paradox with prednisone, there's also a paradox with JAK inhibitors. One of them, baricitinib, actually has emergency use authorization from the FDA to treat severe COVID-19. And so again, it's very possible that, when all hell breaks loose and inflammation is running wild, a drug that tampons down inflammation effectively, like baricitinib, could potentially benefit patients who have severe COVID-19. But of course, it doesn't mean that it doesn't make me worry that somebody already on the medicine who comes into contact with the virus isn't potentially set up for a worse outcome because of knowledge that interferon is so important in defending against this disease. And I'll also throw it out there that there's a drug in development right now that potentially is coming to market very, very soon for lupus, called anifrolumab, which actually blocks the receptor for interferon. And again, it's a drug I'd be very, very nervous about if someone were on this for, say, lupus, again, acquiring COVID-19 infection. So I want to speak a little bit about infectivity periods in patients who are immunocompromised. So the first question is, we've all heard this probably over and over and over again, right? If you have COVID-19, when you're symptomatic, you're supposed to quarantine for 14 days before returning to public life, or if you're exposed to somebody with a close contact with COVID-19. How did we come up with that number? Well, numbers like this were derived from studies such as this one from Korea that were published in the New England Journal that basically show that if you were to basically serially culture virus out of somebody's nose who's got COVID-19, what you'll see is that that basically by the time you get to day 14 to 16, there's no more culturable virus in a patient's nose. And of course, the way we test patients for COVID-19 in the clinic is we swab noses and we do nucleic acid testing. And nucleic acid can remain persistent in the nose of somebody who's been infected with COVID-19 long after they're past their period of infectivity, because there's always some debris left over from the destruction that took place from when the patient was infected. So you can see that the PCR test doesn't really convert till negative until you get out to 30 or 35 days. But the viral culture is negative at 14 days. So that's where the CDC came up with its guidelines to say like 14 days is the quarantine period. Now, it's been my experience in clinic. I've had a few patients who've had COVID-19 whose PCR tests, granted it's an imperfect test for the reason I just told you, remains persistent, but persistent out to like 2 to 3 months. And that's almost certainly not someone who has cleared their virus in the matter of just 14 days. And that suspicion has been borne now by a study published in the New England Journal a few months ago that looked at patients who were immunocompromised. These were cancer patients at Memorial Sloan, I believe cancer patients, I think at Memorial Sloan Kettering, who developed COVID-19. And I don't want you to just really focus on this big sort of plot over here, but I am going to take you in and focus on one of these patients here. So this is a representative patient in this plot. And if we look more closely, what this is showing you, these lines that you see on the screen, is a unique genetic fingerprint for the virus. And actually, if I sort of go back here, you can notice that the fingerprints are different in each one of these patients that are denoted by the different colors here. So each patient in this study had a different, you can call it a variant if you want, a different particular virus as identified by its genome, let's say. And what's remarkable here is not only in this particular patient, these are serial samples collected from the patient, and days after they were actually sick with COVID-19, you can see here that up to day 51, day 61, they remain culture positive in their nose. And when they actually sequence the viral genome out, the fingerprints are practically identical. And this really, and this has been noted for many patients in the study, suggests that these particular patients who were immunocompromised by virtue of having cancer actually had persistent viral shedding and potentially infectivity up to 60 days after their initial infection. In fact, live virus was recovered in 2 patients more than 2 months after the onset of their symptoms. Now, this doesn't mean that there's more severe disease in these patients, but it does mean and have implications for contact tracing and quarantine recommendations. And in fact, the CDC modified its quarantine recommendations toward the end of last year to suggest that if you're immunocompromised for whatever reason, they were recommending a 20-day quarantine as well. But I sort of let these data here speak to themselves, that some patients who are particularly immunocompromised may shed virus for even longer periods after that. And you won't really know it from the PCR tests. You really would only know it by actually getting viral culture, which is very, very difficult to get in patients. So in summary, there's controversial, but probably a small increased risk for severe COVID-19 disease in some rheumatic disease patients. As we've learned from the COVID-19 Global Rheumatology Alliance, where I think of very valuable information, that risk appears to be greatest for those with poorly controlled underlying disease activity. The risk is also greatest for those receiving immunosuppressive medicines like rituximab and possibly others like prednisone. And these are questions that we really need to work out with further study. There's also the theoretical risk posed by medications that can interfere with interferon signaling, although, as I also said, medicines like baricitinib, which do just that, actually have authorization for patients who already have severe inflammation from COVID-19 disease. And finally, as I just told you, treatments that can suppress the immune system, particularly prominently, may actually prolong COVID infection, and that has, I think, implications for how long we quarantine and how we do our contact tracing. So in the last 10 minutes, I really want to speak about the COVID-19 vaccines that are out there and how they've been adopted and how they've been behaving in our patients with rheumatic diseases. There are generally 3 classes of vaccines that are either in the market now or are soon coming to market, we think. The first 2 that are in the market now are vaccines that utilize an mRNA-based technology. Those are the Pfizer and the Moderna vaccines. And then there are vaccines that are called vector-based vaccines. These are the vaccines from J&J and AstraZeneca. And both of these use an adenovirus, which can't replicate, but they use this virus to basically act as a shepherd to bring genetic material from the SARS-CoV-2 virus into the host cells, get the host cells to transcribe and then translate those proteins and mount an immune response to them. The third class of vaccines that aren't in the market yet are the traditional vaccines we've all come to know and love that we get for other diseases. These are traditional vaccines that are peptide or protein-based vaccines. And in this case, these would probably be harmless pieces of the SARS-CoV-2 virus and its proteins that you would inject with or without an adjuvant into the person looking for protection. So some key questions that I suspect a lot of folks would be asking about the COVID-19 vaccines in our unique patient population are, number 1, will the vaccines work? Do the medications used to treat autoimmune diseases temper or abrogate the effectiveness of these vaccines? Number 2, are the vaccines safe? What are the potential side effects that patients can get from vaccines? And related to that, number 3, is there a risk that our disease will flare after vaccination? It's one thing if you have, rheumatoid arthritis and your arthritis flares. It's another thing if you have lupus and your kidney inflammation flares and knocks out your kidneys, right? We wouldn't want that to happen. So these are potential things to consider that are unique to our particular patient population. So let me answer that latter question first. Actually, let me first talk about vaccine efficacy. So will our vaccines work? I'm going to talk primarily about our experience with the mRNA vaccine, since that's what we have the most experience for here in the United States. If you go back to the pre-COVID era, there are conflicting data from studies of other traditional vaccines, the seasonal flu vaccine, pneumococcal vaccines, hepatitis vaccines, that kind of stuff, that suggest that there was a potential attenuation of the immune response in patients who are on some medicines that include what we call anti-metabolites like methotrexate and biological medicines like the anti-TNF drugs that we use. But the data were conflicting and somewhat controversial. it should be there's naturally some concern that there may be similar things seen with these mRNA vaccines, but it should be noted that never before has there been a vaccine using mRNA technology until COVID-19, which is really one of the remarkable stories here about the pandemic. So mRNA vaccines work differently than traditional vaccines, and it's very possible that they can stimulate the immune system differently. You know, the production of proteins from mRNA may more naturally replicate a natural infection by virtue of how the proteins are made inside the host, as opposed to injecting them into the host the way we do the flu vaccine. And it's also possible that mRNA itself may stimulate the immune system as well. So it's very possible these vaccines could be better, or maybe not. We don't really know. So what do we have to go on? So there have been some studies that have looked at this, particularly looked at the efficacy of these mRNA vaccines in transplant patients. So this was a study looking at 430 transplant patients who were split evenly between the Pfizer and the Moderna vaccines. And unfortunately, what the study showed was that the minority of patients had detectable antibodies to the vaccine antigens at a median of 20 days after the single dose. And in fact, those patients who are on anti-metabolites, particularly medicines like Cellcept, mycophenolate, or Myfortic, which some of you might be on, called mycophenolic acid, or azathioprine, for example, which is known as Imuran, perhaps are 1/5 as likely to develop antibodies compared to transplant patients who are taking other medicines as well. Now, again, I'll caution to say that this study only looked at patients after 1 dose. And we know that the Pfizer and Moderna vaccines actually require 2 doses. But at least these numbers were lower that were seen after a first dose in patients who were not on these medicines, for example. So it does imply that there probably is some impaired immune response to some degree. This has also been looked at here in a study. This is a collaboration between those of us here at UCSF and Alfred Kim's group at Washington University in St. Louis, a very, very productive collaboration that has actually looked at antibody responses to the mRNA vaccination group and grouped it by medication classes patients were on. And as you can see here, overwhelmingly, patients who were on B-cell depleting therapy had a more than 50-fold reduction in antibody titers compared to patients who were not on B-cell depleting therapy. And patients who were on prednisone had a 15-fold reduction. These were clearly the biggies here that were associated with reduced, at least antibody responses to the vaccines. And I sort of summarize it here over on the side. You can see here, this is in reduction in antibody titers as you sort of go across the graph here. And those who are on drugs like rituximab, prednisone, those darn JAK inhibitors that I spoke about a few minutes ago, which inhibit interferon signaling. So you would expect that this potentially might be a consequence of reduced vaccine immunogenicity. As well as those on anti-metabolite medicines like methotrexate and such, had reduced immune responses to the COVID-19 vaccine. Now, is there a solution for this? Well, there might be. One potential solution to this might be a vaccination booster. This is a study just published a week or two ago, looking at patients who had solid and hematologic cancers, solid tumors and hematologic cancers, who received the Pfizer vaccine. After the first vaccination, much like the study I showed you a couple of slides ago, the minority of patients had detectable antibody titers after their first dose. And in fact, you can see in the solid cancer group, only 38%, and in the hematological cancer group, only 18% had detectable antibody responses to the vaccine. However, after that second dose that we get, which is that booster dose, if you looked at patients who got the boost versus patients who didn't get the boost, the majority of patients who got the boost actually now had a detectable antibody response. 95% of patients in the solid cancer group, 60% of patients in the hematologic cancer group, versus nobody got a significant boost in their antibodies if they didn't get the booster. So this suggests that a booster may be just what the doctors ordered. And in fact, who knows, maybe even a third dose might be even better as well. These are questions we really don't know, and it's something we really need to study, I think, going forward. So some key points I just made: antibody titers may be reduced in some patients with autoimmune diseases who take certain therapies, especially drugs like rituximab that wipe out B cells, and possibly worse with drugs like prednisone, JAK inhibitors, and methotrexate type drugs. There is a suggestion that there's a corresponding reduction in the ability to neutralize the virus in these patients as well. I didn't want to really get into those data, but the reduction in antibody responses probably does correlate to some impaired ability to neutralize the virus. And it does appear that if you boost, you can augment the immune responses to these vaccines. And something that hasn't been studied yet, but is being actively considered, what if you cross boost with a different vaccine than the one somebody got originally? Is it possible that you might actually be able to have even a better immune response if you actually do that? That's a strategy that's being looked at now in the United Kingdom in a study that just got underway, I think, a couple of weeks ago. And we'll learn more about these questions, hopefully, in the coming months. Now, I'll caution you with these vaccine studies. It's really unknown if the reduction in these antibodies actually reduces the vaccine efficacy. And I'll sort of throw it out there to say, like, it's not like we have a rash of COVID-19 breaking out in our rheumatic disease patients. And it really does suggest that even though the antibody titers may be reduced, it's possible that even a reduced amount of antibodies is still sufficient to not only prevent viral infection from establishing itself, but it's also possible that there may be T cell responses that are not measured in these studies that are also important, not only for potentially preventing, but in clearing viral infections and preventing severe disease. So it's very, very possible that a lot of what I just showed you is academic and more scientific for how we study the immune system. But in terms of real world efficacy, it's possible that many, if not most of our patients getting vaccinated may very well have adequate immune responses to at least prevent severe disease, hospitalization, and death, if not the disease in its entirety. What we don't know is, even if that's the case, is it possible that this reduction in antibody titers, even if it's sufficient still to prevent or prevent severe infection, might it actually lead to a shorter duration of protection? Might these patients who have lower antibody titers need to be boosted sooner? Again, these are questions we don't know, and questions that we need to answer. And as I also said a few seconds ago, it's unknown how these medicines affect T cell responses. We suspect they probably, inhibit them a little bit, but it's very, very possible that there's more than enough of a T cell response and maybe even antibody responses in most of our patients to still get reasonable protection from these vaccines. So the recommendations to everybody out here is, and I'll again paraphrase Dr. Fauci, any vaccine response is better than no vaccine response. So live your life as it is. If you want to go visit your grandkids, go visit your grandkids, go visit your family. Real world evidence and experience, I should say, really suggests that the vaccine is reducing disease and disease severity everywhere. And it's not like we're seeing a rash of COVID-19 persisting in transplant patients or in patients with rheumatic diseases and stuff. It looks like we're all benefiting from the vaccination program that we have here. The CDC itself does not recommend checking antibody titers, even in our patients who are immunocompromised, because the actual real world vaccine efficacy is likely not fully reflected in whatever numbers it is that you get. And it's very possible that you check your antibody titers and they're low or they're negative, and you'll be all bummed out and lock yourself in your house. And that's not what should happen. You should feel reasonably confident that you're getting something out of these vaccines. And again, the real world efficacy data, which is available, which we all see every day, suggests that is exactly what's happening, that these vaccines are working probably in everybody to some degree. But if you're still concerned, continue to practice what works. And the best thing you can do is to convince your loved ones and your social contacts to get vaccinated, right? If you want to protect me, you should be vaccinated, right? That's the best thing that you can recommend. And if you're unsure when you go out, continue to wear masks and socially distance and conduct your activities outdoors as you need to. But again, I think living your life as it is extremely important once you've been vaccinated. Now, are the vaccines safe in patients with rheumatic diseases? I'm going to spend just another couple minutes, and then I think we'll get to our question and answer section. So there are theoretical risks with these vaccines, particularly in patients with autoimmune diseases, because these because traditional vaccines that we use contain adjuvants that stimulate the immune system. So there's a theoretical risk that you'll stir up the bad pot, so to speak, with a vaccine and cause a disease flare. Now, we know from other vaccines, such as the pneumococcal vaccine, the other conjugate pneumococcal vaccine, as well as seasonal influenza, that these vaccines are safe to use in our patients with rheumatic diseases. These vaccines have not been shown to trigger flares on a large scale, and they're highly recommended to be used in our patients with lupus, rheumatoid arthritis, and other rheumatic diseases, because the risk-benefit ratio greatly supports using these vaccines. In terms of, there are also reports with traditional vaccines of autoimmunity that's been induced, such as Guillain-Barré syndrome, which is an autoimmune paralytic disease that can sometimes occur after vaccination with the seasonal flu vaccine. To date, there have been no reported cases of Guillain-Barré or there's been no signal, at least I should say, for Guillain-Barré with any of the vaccines that are used in the United States. And this is, we have a large database called the Vaccine Adverse Event Reporting System, or VAERS, that's been closely monitored by the FDA and the CDC. And to date, there are 287 million doses of the vaccine that have been recorded, that have been given. And as I said, there's no signal that diseases such as Guillain-Barré are elevated in patients who've gotten any of these vaccines. Now, does the COVID vaccine cause rheumatic diseases to flare? As I alluded to earlier, there's no evidence of rheumatic diseases flaring after traditional vaccines, and there are none that have really been, this has not really been suggested to occur in patients who have the COVID-19 vaccination after all. That said, there have been anecdotes of diseases flaring, and you can find them for any disease you're interested in, whether it's rheumatoid arthritis or lupus or myositis or vasculitis or inflammatory bowel disease. You'll find case reports of patients whose disease has flared in the immediate period after they've gotten COVID-19 vaccination. And here's an example of one patient whose rheumatoid arthritis flared after COVID-19 vaccination. And I'll leave it up to you guys to decide. Again, there are no large scale data that suggests that there are flares, but this is a case of a 55-year-old man with rheumatoid arthritis, which had been in complete remission for a couple of years. He had 1 day of mild joint pain after he got the first dose of the Pfizer vaccine. 12 hours after he got the second dose, he developed a large right knee of swelling and pain, and was treated with prednisone, relatively decent dose of prednisone, for up to 9 days, but remained symptomatic. And so he came into the clinic, had fluid taken out of his knee. This is the actual fluid that was taken out of his knee here, and it was very, very inflammatory. And again, is this rheumatoid arthritis flaring? Is this some post-vaccine response? Is this just coincidence? Nobody really knows, but so we do know about specific case reports like this, and I always have my eyes and ears open and suspicions out there. But to date, there's no evidence that rheumatic diseases themselves flare on any large scale after COVID-19 vaccination. Are the vaccines safe from other side effects? Well, there's this thrombosis story that many of you may have heard of that's possibly unique to the vaccines that are adenoviral based, those vector vaccines I showed you earlier. These are the vaccines that are made by Johnson & Johnson and AstraZeneca, and they have indeed been associated with an increasing number of case reports of clotting, particularly in the veins inside the brain, what are known as cerebral venous thrombosis. Now, what's amazing about this, why this is a credible report, is because you can begin to see a credible clinical picture of the disease. These are mostly young women. These are usually clots in unusual areas like the brain and other internal organs like the intestinal circulation, known as the splanchnic circulation. Most patients who get this, in addition to having clots, have a precipitous drop in their platelet counts. And this occurs in close proximity to these single dose vaccines. So it's a very, very credible clinical story, as opposed to some of the random case reports of other things you hear out there. This is a credible story. And in fact, when these patients with this unusual form of thrombosis were actually studied, it was found that most of them, almost all of them, in fact, in some of these studies, actually made a specific antibody to a platelet-derived protein called platelet factor 4. Antibodies to this particular protein have been known in other diseases to cause clotting. So again, this is a very, very believable story. Now, why is this important to us? It's not. This is a very, very rare thing, but you should know that Jane Salmon's group up in Cornell reported many years ago that lupus patients who make, like I said, lots of autoantibodies can make antibodies to platelet factor 4. In fact, 9% of patients in her lupus cohort who also had antiphospholipid antibodies made antibodies to platelet factor 4. And if they had antibodies to PF4, they were actually 4.5 to 6 times more likely to clot. And so again, something to sort of keep in the back of your mind. Also in the news lately has been this incidence of heart inflammation, otherwise known as myocarditis. These are primarily reported with the mRNA-based vaccines. These are the Pfizer and the Moderna vaccine. I'm going to give you the latest CDC update as of last week. There are case reports from Israel and the United States that includes that very, very large vaccine database, as well as one from the Department of Defense. They reported a few cases of myocarditis. These are predominantly in adolescents and young adults, more often in males than in females, and more often following the second dose of the vaccine rather than the first dose. This condition typically occurs within 4 days after vaccination. And luckily, most cases appear to be mild, although follow-up in these patients is ongoing. But what's the most important thing? This has now been adjudicated by a vaccine safety group at the CDC. And it really does appear that these rates of myocarditis are not that different from what would be expected from baseline rates that you'd see in the general population over this certain period of time. So whether or not this is a real association with the vaccine or not, I still is a very, very big question. It looks like for now, it is not something necessarily linked to the vaccine, but may just be coincidence, because there is a background rate of viruses in the world, and viruses cause myocarditis. And that background rate may be exactly what's being reported here. It's really unknown, I think, at this point. So in summary, all vaccines appear to be safe for use in rheumatic disease patients who are taking or not taking immunosuppressive medicines. The risk-benefit profile overwhelmingly favors vaccination of all patients with autoimmune diseases. Some efficacy, even if it's limited, is better than no efficacy, and there's probably more efficacy than you realize, even if you're told your antibody test is low or negative. I really want to leave you with that thought. But there's one exception here in the safety realm, and that is potentially avoiding the adenoviral vector vaccine. If you know someone, or you are someone who has a history of thrombosis, especially in thrombosis when you were given a drug like heparin, or if you have a disease like lupus, where you have known antibodies that can be associated with clotting, things that we call antiphospholipid antibodies, or even antibodies if it's known to platelet factor 4. In these patients with lupus, for example, I'd be very reluctant to give them the Johnson & Johnson or the AstraZeneca vaccine for reasons that I sort of just discussed. And so with that, I'll end my talk. I'll thank all of you. And again, I'll sort of summarize that, yeah, it's only been a year and we've learned so much about this disease, but this is really just the end of the beginning. We have so much to learn and so much more to study, particularly on our patients like you out there. And I encourage all of you to stay engaged, but to live your lives as you see fit, and ask whatever questions you want to right now. So thank you.
Okay, thank you, John. I wonder if you could stop sharing your screen. Good, we should both be back. So thank you very much. That's an exceptionally thorough review. We do have a lot of questions, so I'm going to try to get to them quickly without any big introduction. And maybe I'll get to the first thing to link to what you said last about living your lives, because there were immediately a couple of questions about what you really mean by living your lives. And I'll read them both to you and have you comment. The first one says, should we wear 1 or 2 masks if we live our lives? Going to a store, seeing our grandchildren who are too young for vaccines, but go to daily daycare with other children. That's one. I'm going to read them to you both at the same time to move things along. Second one, do you think it's likely that people with rheumatic conditions are being more cautious, and that's why we're not seeing more cases in the community? In that case, if we do relax and, quote, live our lives, isn't it possible that we'll see a surge?
Those are excellent questions. I think, the most important thing, like I alluded to before, is to really encourage those in your immediate vicinity to get vaccinated, right? We all protect one another, right? That's really the purpose of masking initially, right? Was to prevent ourselves from spreading it to others, at least as much as preventing others from giving us the infection. Do you need to wear 2 masks? No, I think it depends whether you're, so I'm assuming these are vaccinated patients asking questions after they've been vaccinated. If you've been vaccinated and you have, as I alluded to before, we don't know for sure, but we suspect that you probably have some protection, particularly against the severity of the disease. And so I think, the best advice I can give is really to sort of, again, paraphrase Fauci and others who've basically said that, as more and more people get vaccinated in the United States, and as the prevalence of the virus decreases in our population, right, the risk of transmission from one person to another drops as well. So if you're in a very high endemic area where COVID-19 is still very, very endemic, and you're worried about, how good an immune response you got, I would continue to wear a mask. I would continue to socially distance. I would continue to dine outdoors. I wouldn't go into the symphony or places like that and inside with 15,000 other people. I would probably continue to be pretty vigilant until I knew that the infection rate in the community I'm in is below a certain percentage. And what that percentage is, the epidemiologist can tell you. But here right now, the positivity rate in San Francisco is somewhere around 2% or less than 2%. And so you can kind of figure out, if you're vaccinated and you presume that you have some reasonable efficacy against a chance encounter with the virus, and you know that the virus is now exceedingly less common in the community, replicating less commonly in the community where you live in, you can make the judgment about how loose you want to be with masking and close contacts and things like that. Right now, I would feel fairly confident that if you're on, unless you've had your immune system completely ablated, basically destroyed by chemotherapy or some intense immunosuppressive regimen, and you've received 2 doses of the Pfizer or Moderna vaccine, and you're in a low endemic region, like say here in San Francisco or in California like that, I think you don't need to wear your mask necessarily around your family or grandkids or anything like that.
Okay. Next category, there have been a number of questions about the interpretation of low antibodies or no antibodies and how significant that is. So I just I know you addressed that in general terms. Maybe I'll put it in a specific term. I'm not immunosuppressed. I don't have a rheumatologic disease. I got the Pfizer vaccine. And then I had an opportunity to get an antibody test at my daughter's school, and it came back with no antibodies. I think a lot of people are getting tests back with no antibodies. And my understanding is that there are some tests out there that don't measure antibodies to the spike protein. So people who get a test and it says no antibodies, can they be confident that they don't have antibodies, or is it possible that the test is the problem?
That's a great question. You're getting into a lot of specifics here. So yes, there are different blood tests that test for antibodies to the coronavirus. The 2 major components of the virus that we test for antibodies to are something called the nucleocapsid component of the virus and the spike protein of the virus. The so there are no vaccines that I'm aware of out there that generate antibodies to the nucleocapsid. So that test is particularly relevant to test people for a somewhat recent exposure if they've actually had natural infection with COVID-19, with SARS-CoV-2. Their nucleocapsid antibodies will be positive. Conversely, if you've been vaccinated, the vaccine specifically contain the spike protein in that, or have the ability to mount an immune response specifically to the spike protein. In that case, antibodies directed against the spike protein will not be detected by tests that are specific for the nucleocapsid. So that's number 1. So the first thing you want to do if you're testing yourself commercially, and again, the CDC does not recommend you do this because for a whole host of reasons, even if you find antibodies, we don't know that those specific antibodies themselves are the protective ones, nor do we know the level of antibodies that are considered protective against an infection, because it may be, if I'm sitting around what do you call them, super spreaders, I need to have more antibodies. And if I'm around grandpa who's got a couple of virus particles, I need we don't know the amount of antibodies that are protective, right? So, and nor do we know what T cells and other parts of our immune system do to protect us. So again, the CDC, for a whole bunch of reasons, doesn't recommend checking antibodies on everybody. That said, if you happen to look at a specific antibody test to the spike protein, some are better than others at correlating with vaccine response. So if you look in the initial studies that were published in the medical literature, there was a very, very specific test that was designed to detect these antibodies. And most patients, 90+% of patients, 95% had beautiful antibody responses, robust to these vaccines. The commercial tests that are available out there have varying abilities, varying sensitivities at detecting these antibodies that are out there. So there are a couple, I don't want to get into the specifics here. There's one made in Italy, for example, there's one made by Roche that are considered better, for example, than other ones that are made by other manufacturers. The assay that we use here at San Francisco General is pretty darn good. It's another commercial assay, but it's probably not as good as some of the ones that the vaccine companies themselves used in the clinical trials. And it's one of the reasons why the CDC doesn't recommend checking antibody titers, because the tests that are out there from various commercial entities may not be as good. But if you really want to know, then there are a couple, you can message me privately. I can give you the names of a couple of the companies that make tests that the vaccine companies themselves use to measure the antibody responses. And some of that you can get them commercially, and you can request that LabCorp or Quest or these other companies get those tests for you. And so there are ways to do that.
So you alluded to this in your talk, but I think given that we're talking in this area and there seems to be so much interest in the chat, let me give you an opportunity to be explicit. What is the evidence right now that a low or no antibody response to the vaccine increases the risk of infection for someone with rheumatologic disease? Or do you think it does?
There's no evidence that right now that it increases the risk of disease. There's none. So why are we studying this, right? I mean, well, we love science and we want to know the nature of the immune system. So we're looking at just natural immune responses in our patients compared to normal people. That's one reason. It's because knowledge for knowledge's sake is important. And two, it's important, I also think, because we know that immune responses to natural infection with the virus wane over time. And it's certainly, that doesn't mean that if you're a year out from your COVID infection, you're going to get COVID again. But it's clearly been shown with other coronaviruses, with the original SARS virus, with MERS, with others, that immune responses pretty much drop down to almost undetectable when you get more than a year or two out from natural infection, at least in many patients. So it's possible, if you don't mount a vigorous immune response in the beginning, it's possible that your immune response may tail off sooner than somebody who is not immunocompromised, right? And so the reason we're studying this is not to see necessarily whether people are protected or not now. They probably are, but whether or not there's the potential to need a booster, right, in 6 months or 12 months. We don't know that. And so these are hypothesis generating questions from these studies. But I think it is important in the back of all of our minds to know that the immune responses may not be completely normal, but they may not, that doesn't mean that they're not protective. And so that's why I'm not being flippant, I'm being, explicit when I sort of say that you can feel reasonably sure that you're getting at least some decent response, I think, to these vaccines, because the real world data suggests that the viral prevalence is plummeting. And I haven't seen a slew of patients admitted to my hospital here in the last couple of months with rheumatic diseases and COVID-19. It just hasn't happened in vaccinated patients. There'll always be a few breakthroughs here or there, but we're not seeing a rash of this. So I think it suggests that not only is the prevalence of infection declining in the real world out there, and that's benefiting all of us, but probably the vaccines are also protective in our immunocompromised patients to some degree.
I want to follow up on your comments about boosters. There were a couple of questions about that. The first was a clarification that when you say booster, you really mean beyond the 2 doses. Yes. And the second question, I'd be interested in your thoughts about. I'm sure there's no data, but here's an interesting question that was posed. If you are a rheumatic disease patient who's on one of these drugs that will dampen your response to the vaccine, or maybe you know that you didn't have a good response to the vaccine, should you consider a holiday from your immunosuppressive drugs and get vaccinated during the holiday?
That is a great question. Thank you for asking the question. Whoever asked the question, it's a great question. I was going to include it in the talk, but there have been no studies that have looked at this. There is guidance from the American College of Rheumatology, however, on this, based upon experiences with other vaccines. Now, as I showed you in my talk, these current vaccines are very, very different than the traditional vaccines of injecting dead influenza virus and dead flu virus into someone. Using an mRNA vaccine is very, very different. So take what I'll say here with a grain of salt. But if you look at vaccination to the flu vaccine, for example, there have been studies that have shown that if you take a 1 or 2 week holiday with methotrexate, for example, if you're on methotrexate for rheumatoid arthritis and you take a 1 or 2 week holiday, you get a better antibody response to flu vaccination than you would if you didn't take a holiday. And again, these are not there are challenges and issues interpreting all of these various studies that have been done, but that's one of the plainer ones that I've actually seen. There are other medicines. David, you pioneered a medicine, abatacept, that's used now in a lot of my rheumatoid arthritis patients. Abatacept works by basically preventing T cells in our bodies from recognizing new antigens, new infections, for example. If anything, abatacept may even make those T cells go to sleep for a long time. Not only will they not recognize and react to a new infection, they may become, at least for the long term, what we call anergic or inert to that. And it's conceivable if someone's therefore getting vaccinated at the same time they're getting a medicine like abatacept, they may develop energy to the vaccine. So we don't have data to suggest. We do know from studies looking again at flu vaccines and other vaccines that patients on abatacept don't mount very good antibody responses, if at all, to some of these vaccines. And so, so I've recommended some patients on abatacept, again, with no data to back me up. Even in our study that I showed you some data from, we have very, very few patients on abatacept in that study. But for my patients on abatacept, I've been holding several doses of abatacept prior to their vaccinations.
I'm glad you mentioned that. One of the questions actually was someone who specifically commented that they were on Orencia, which is abatacept.
Yeah, Orencia, thank you.
So,
yeah, Orencia.
So for that person in the audience, John has just answered your question very directly. We're right at time, and I want to respect people's time. I know you're at liberty in a Zoom to leave without offending anybody. We're not going to go much longer, but I do want to try to get sort of rapid fire answers. And one question that came up in numerous forms has to do with TNF inhibitors and whether the TNF inhibitors increase vulnerability to the virus, how the vaccines might interact with TNF inhibitors. Humira in specific was asked about.
Great questions. Let's start by the last medicine I was just going to get to a second, though, was rituximab. Rituxan. That's a medicine that if you're on it, we've been holding the vaccine until people's B cells grow back, and then holding their next dose of rituximab. And then once the B cells come back, we've then vaccinated as well. So those are the drugs that I would say out there we really do believe in a holiday for. When it comes to the TNF drugs in particular, in my clinical experience, I haven't seen particularly worse disease in patients who've been on, say, Humira, for example, or Enbrel or Remicade, who've had COVID-19. And I think that those data are borne out in the registries so far, that we haven't seen huge signals of horrible disease and death in patients on anti-TNF inhibitors. I do think in some of the patients who had extended, what I think had extended viral infections, some of them were on anti-TNF inhibitors. So whether or not being on an anti-TNF drug prolongs the duration of infectivity, we don't know. But I've had patients remain PCR positive out of their nose for over 3 months after their initial infection while they're on an anti-TNF inhibitor. That's been my experience in some. And it's made me wonder whether or not there's delayed viral clearance, because taking the limitations aside, if you're still positive 3 months out with that particular test, you probably had virus in that nose also for some period of time as well. So in terms of vaccine, we haven't seen any reduction in vaccine efficacy to date yet from the anti-TNF drugs, but we don't really know. And
in a variation on the comments about low antibody titers, there's a question that says, if you have had, let's say, for example, the J&J vaccine, and you have a test and you didn't make antibodies, should you try to get another vaccine with a different manufacturer?
It's not recommended right now to do so. There have been a couple of cases for specific reasons I will get into. I will get into one of them, where I've requested from our pharmacy to get a second dose, say, of J&J, or a third dose of Moderna, for example, or Pfizer. And the pharmacies are very reluctant to do so, because you have to remember these vaccines are not FDA approved. They're under emergency use authorization. And so the FDA is very strict about how these can be given. And unless there's been a mess up in how the doses were delivered to someone, like the wrong dose or not enough, the pharmacies are extremely reluctant to go against the FDA guidance to give these outside of the narrow window with which they've been authorized to give these. So you may not even be able to get one. That said, the one exception I can tell you where I got the pharmacy to approve it is as someone who was on Rituxan. We were waiting forever for his B cells to come back, and after 9 or 10 months, they hadn't come back, and he was desperate to get the vaccine, and he got it, and this particular person got no antibody response. And so once his B cells finally came back, I was able to beg and plead to the pharmacy in his particular case to try to give him another boosting dose, and they agreed to do it. But by and large, it's probably something you can't get yet until the drug is either FDA approved, or there've been studies that show that boosting actually makes a clinical efficacy difference.
Great, thank you, John. What's happening, folks, is that questions are coming in faster than we're answering them. And so I do want to try to give everybody an answer to their question, but I have a feeling it's going to be impossible.
And the fact that nobody has left, I'm looking at the numbers here, suggests that it's okay that we're going over.
John has mentioned that people can try to reach him privately. The same with me. If you want to follow up, I'm happy to try to triage or answer questions that you feel haven't been answered. We're both easy, our emails are easy to find at UCSF. I will ask you maybe one more that covers several of these questions, not all of them, and that has to do, you alluded to some of this, but I think maybe a little clarification or extension is necessary. And that has to do with who shouldn't get the vaccine. You certainly talked about the clotting problems. Somebody has asked if they've had a previous adverse reaction to the flu vaccine, serious adverse reaction, a brachial plexopathy. What would you recommend?
I would recommend getting this vaccine. I think even if someone has had a history of Guillain-Barré, which is the ultimate vaccine-mediated immune condition that destroys nerves and renders people paralyzed, the Guillain-Barré Association of America recommends getting this vaccine because there have been no signals of recrudescence of the disease from this. These vaccines are very, very different than the flu vaccine. We're learning that now more than ever. And I think, there are a lot of reasons why someone can develop, for example, a brachial plexopathy after influenza vaccine. It depends upon, there could be a whole host of things that could go on, but I wouldn't be concerned. I think that the benefits of this vaccine so far outweigh that even in patients who've had previous vaccine reactions, unless they are, like I said, specific to the adverse events that are seen with these particular vaccines, like clotting, that the recommendations are as strong as they could be to get the vaccine.
Great. Okay, well, I'm going to thank you very much, John, and let you go if you choose to, and encourage the others who have questions to feel free to follow up with us. The whole purpose of this is to answer them. And if we have to answer them after the fact, we will. I'm going to share my screen just one final time, if I may. Let's get rid of this. Are people seeing my screen?
Yes.
Good. I just want to express my thanks to you, John, to the sponsors of this program, the Russell Engelman Center and the Rheumatology Division in the Department of Medicine at UCSF, especially to Christy Abley, who chaired the volunteer committee, and to all of the volunteers who worked with Christy, who actually set this program in motion, not just tonight's program, but plans for the ongoing educational program. Thanks to all of you, and thanks to PJ Handlin, the executive director of the Russell Engelman Center, who worked hard to put this together, and to Zach Concepcion of the Department of Medicine, who helped us with all the technical aspects. We really appreciate it. Thank you also to those of you who participated and enriched the discussion with your questions. I hope you all found the session informative, and we will be in touch again as topics for the fall webinar series are finalized. I just want to, let's see if I can advance this slide. If you're, in the meantime, to hear more from us, if you're interested in learning more about the programs that we offer, or if you're interested in providing support for the Russell Engelman Center, here are the links to the Division of Rheumatology on top, and to the support site below that. I have mentioned before, I want to remind you before we close, that this has been recorded. We'll post it on YouTube within the next few days and let people know how to reach it. So I hope if you felt it was useful to you, you'll feel free to mention the program to friends and family who may not have been able to participate tonight. Hope you all have a very nice evening, and thanks again for attending, and I hope we see you at future programs. Good night, everybody.